Welcome back to another episode of The PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past. Optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. Over here, we are redefining what success as a physician associate looks like, and probably more importantly, what it feels like. Today, I have a special guest on the show, Joann Timberlake. Joann is an experienced ERPA who recently pivoted her career and now enjoys seeing patients in the field of radiation oncology. She says that her daily goal is to treat her patients' mind, body, spirit, and soul. We're going to talk about radiation, what the difference between different doses of radiation are, whether they're therapeutic, destructive, whether they're helpful or harmful. We're going to talk about treating the patient as a whole and how each one of us can incorporate that into our practice. We're going to give you some tips on how to pitch that local radiation oncology practice that you have had your eye on. And we're generally going to talk about quality of life and how it is being the very first of a PA in a group with a new specialty for the PA and having a new PA join the practice. You are not going to want to miss this episode. Joann is a delight. It's awesome. I cannot wait to share this conversation with you. So without further ado, here she is, Joann Timberlake. Awesome. So Joann, welcome to the show. Thank you so much for being here.
Thank you for having me, Tracy. It's amazing to be here.
So tell us a little bit about you and your journey to becoming a PA and what you're doing now.
Um, basically, I had met a PA who was specializing in cardiothoracic surgery. He really took me under my wing and basically was saying, if you don't know what you want to do, why don't you kind of shadow me in the OR and see if it's something that you want to do? And after that first shadowing experience, I was hooked. I said, how do I do this? How do I get into PA school? So I basically followed in his footsteps, went to the same undergrad as him, and he was more than happy to write me a letter of recommendation. And I just fell in love with the profession. I like the versatility. I like the fact that you get to help patients every single day, and you get the work home life balance that you get to come home and be with your family.
Absolutely. So what specialty are you in now?
I'm currently in radiation oncology.
Okay, so let's unpack a little bit about radiation oncology. I think radiation is one of these things that both providers, patients, and even the general public have a lot of misunderstandings about. Do you find that when patients are coming in to see you?
Yes, that's the number one fear. These patients that come in for the first time to see myself or my colleagues, they are terrified of the term radiation. I think it's just gotten a really bad marketing campaign in society because the thing that most people associate radiation with is just destructive radiation. These nuclear bombs, all these things that have happened in history. Oh no, this is going to be some invisible death or some cancer producer, and I have cancer. And so, what they don't know is sometimes it's more of a dichotomy. The thing that can damage can also cure.
Mm. So these are cancer patients. Are you treating any non-cancer patients, or you're only doing radiation for oncology patients?
That's a very good question because radiation can also treat a number of non malignant modalities, such as trigeminal neuralgia. And
Ah,
it
okay.
actually can treat keloids, avia malformations, and meningiomas.
Awesome. I didn't know that. I work in plastic surgery, so I'm literally writing that down so that I can send my keloid patients to our radiation department. So, someone comes to you and they're seeing you for an opinion because they have most of the time a diagnosed tumor. They've either had surgery, some sort of other treatment, or they're coming to you for primary treatment. So, what does that look like when you see someone for an initial consult?
Initial consult usually for example. It's usually, let's say breast. Breast, they've had the breast surgery, they've seen a breast surgeon, they've seen a medical oncologist, and usually we're the last kind of road to healing and hopefully curative treatment. Um, Patients sit down with us and they're, of course, terrified of the word radiation. I don't want to have radiation. Radiation's terrible. So a lot of the first consult is just kind of destigmatizing what they have heard in society. And usually after that discussion, they say, oh, okay, I could do this. Let me just try this. And it's not invasive. It causes just, minor symptoms, side effects. But oftentimes at the end, when they're done with their treatment, they tell me, this was not as bad as anything I experienced prior. This was not as bad as chemo. This was not as bad as surgery. This was easy compared to what I had anticipated.
But it does require a big lifestyle adjustment. So, in my experience doing some surgical oncology earlier in my career, they have to come typically frequently and for a while. Is that true for most of your patients?
Yes, yeah. So it is a dedication. It's usually 5 days a week, about 20, 30 minutes appointment. 1 day a week, we see our patients after treatment. So we keep a really close eye on them. We look for any new side effects that may be occurring. We often treat it very symptomatically. And it's a dedication. It's usually sometimes 44 treatments, but the latest in technology, especially with breasts, is they've been doing more of 20 treatments. And that's just not as that's half the time that, 44, 35 treatments, how it used to be back even 2 years ago.
So, decreasing amount of treatments means they don't have to be treated for as long. So, they're still doing 5 days a week, but for a shorter period of time.
Correct. Yeah.
Okay. And so typically when they're coming in for one of those visits, they're seeing one of the rad techs who is then like setting up all of the things and they're getting treatment. And then 1 day a week, they're seeing the provider.
1 day a week or ad hoc. So if they need us, we're always there. Sometimes we're seeing patients on the actual, table if they've got any concerns. So basically on call for our patients.
Sure. And so how long have you been doing Rad Onc as your primary specialty?
This is currently my 4th year.
Awesome. Okay. So let's kind of back up a little bit and unpack if someone is listening and they've either not had a patient that had radiation, they are not that familiar with it. How does it work? How is it different than like I think of when we talk about radiation, I think about like flying in an airplane. I remember in PA school learning, oh, when you're flying in an airplane, I honestly was not paying that much attention this day, but like some fact about chest radiograph versus flying in an airplane and how much radiation you're getting from like a chest x-ray versus flying in an airplane. So you don't have to tell me the actual numbers, but I like, can you unpack for us like what is that radiation, the same kind of radiation that we're getting if someone is having an x-ray versus having therapeutic radiation for treatment for something?
It's similar, but much lower dose. Radiation treatment, therapeutic radiation is more like X-rays, high dose energy. Traveling an airplane, transatlantic flight is equivalent to probably about one chest X-ray. It's not too much. Chest X-ray is very, very extremely low radiation. We have radiation everywhere. We're exposed to radiation all the time, and our bodies can handle a certain amount of radiation. It's just the problem is when our bodies exceed that amount of exposure, a certain amount of exposure that can cause harm. So anything, light, radio waves, anything can cause, can emit radiation. Now, radiation for therapeutic radiation, that's very high energy. Um, we're talking about ionizing radiation, which is the bad, supposedly the bad radiation. There's not ionizing and there's ionizing, and this is just high energy delivered to the actual tumor spot. So that's very different than low dose radiation from the ground, airplane, transatlantic flights. That's just it's very different.
And the difference is that it's targeted. So you're using higher energy, but also more focus. So it's not going to the entire body. It's just going to the area, the region, the tumor, whatever it is that you're aiming to treat.
Correct.
Okay. And I remember, I feel like I'm showing how rusty I am at certain areas of medicine on these podcasts sometimes because I'm like somewhere in the deep recesses of my brain. I remember one of my professors saying surgery is local control, radiation's regional control, chemotherapy is like systemic or complete, like treating the entire body. Do you
Uh,
guys break that down for patients? Is that accurate? I don't even know if that's
That's
true.
absolutely accurate. Yes.
Okay.
Yeah.
In my brain, these things are
Yes, you got that absolutely right. And that's exactly what I explain to my patients too. Because oftentimes they'll come in and they'll be like, yeah, I had my chemo a couple months ago and I have radiation to, I don't know, let's say some body part, say the breast, and it's just easier. And now I've got numbness in my toes. And is that from the radiation? No, it's not. It's actually from the chemo because it's systemic. So you're right. You're absolutely right.
And when people come in, so these patients are typically have at least been seen, possibly treated by surgical oncology. They have a medical oncologist who is managing them from a chemotherapy standpoint. And then they come to you. And I think that this is probably a very common concern that you hear. People are like, hey, I'm here to be treated for my cancer, but I also know that radiation causes cancer. So, how do you kind of talk to them about that and help them to understand that although that's true, it's also treatment?
I just explained that, longitudinal studies show exactly how much radiation is needed to cure a particular part of the body. Certain areas of the body are more sensitive to radiation than others. Bone marrow is more sensitive. So they've known for decades exactly how much radiation is to be delivered to a particular body part to treat cancer, um, and to not go over that particular, what we call gray or dosage.
Okay. So there's like a threshold, and I think like sometimes you'll reach the threshold, and this will say like this is all that we can do for this region or this body part because otherwise we're tipping over into that area where the risk would outweigh the benefit.
Absolutely. Yep.
Okay. So you're seeing patients who are, it sounds like sometimes towards the end of their treatment, not the end of like they're cured the minute that they stop receiving radiation, but that they've already done surgery, they've already done chemotherapy, some of them, and then they come to you. And I think that with cancer, particularly, it's not just about the tumor. There's a person walking around dealing with the social side effects, the work related side effects, all of the things that come with becoming a cancer patient and getting cancer treatment. So, how do you in your practice, or how does your group deal with that? Kind of treating the whole patient. How do you take time to make sure that you're addressing all of their concerns, even if it's not radiation specific?
I believe cancer is all encompassing. I mean, it is. It affects every part of that patient's life the minute they get that diagnosis. Um, it affects their physical aspect, mental, emotional, financial. It affects every person in that family, immediate and non immediate, once that diagnosis is shared. So we have social workers who specialize in oncology on our staff. We even have a psychiatric PA who has a lot of oncology experience to help our patients kind of get through this traumatic event. I mean, it is a traumatic event. We also have case managers. We have genetic counselors. We have physical therapists. That kind of help with all of the modalities and all of the things that encompass cancer.
So, what advice do you have? A lot of the people listening are providers, whether new PAs or seasoned PAs working in more than likely different specialties than radiation oncology. How can that person, in the constraints of like they're at the family practice office or they work in ortho or some other setting, how can that person kind of step back and remember that we're taking care of the whole person, not just the blood pressure, the cholesterol, or the osteoarthritis in their knee, what are some reminders or some things that we can do on a day-to-day basis to make sure we're taking care of the whole patient?
So, one of the things that I've found that is very, it's a simple question to ask patients that I have found to create a better bond with our patients. And that is walking in the room and asking, how are you feeling? Not how are you doing? How are you feeling? Because when most of my patients say, I'm feeling good, that's great. Elaborate a little more for me. What's going great? Because I want to hear it. And some of my patients like, well, you know what? It's so so. Why is it so so? And I always take that time to listen to their response, how I can actually help them at that moment. Um, do I just need to be a listening ear? Because sometimes that's just all that is necessary. Um, do I need to provide them resources or referrals somewhere? Because whatever's bothering them at the moment is taking precedence. So I try to just constantly just look at the whole patient and see what's going on in your head. Like I know what's going on in your body, but what's going on in your head? Everything okay? Is family okay? Is work okay? A lot of these cancer patients, their work is modified or they're on disability. And that is another mental toll on them.
If you only take one sheet of paper to your next negotiation, let it be the PA Pay One Sheet. It's a tool designed to walk you through setting up the ideal outcomes, assessing the situation you are negotiating in, and it even includes a reminder of which negotiation skills you can use. Stop what you are doing. Download the one sheet, print it out, fill it out, and literally bring it to the table with you when you are negotiating next. It's designed specifically to work in healthcare settings wherever you are. You can use the PA One Sheet to get the best deal, the biggest raise, and to help your confidence walking into your next negotiation. Head to www.tracybingaman.com/one, that's ONE, to download your free copy of the PA Pay One Sheet and start prepping for your next negotiation today. It's linked in the show notes, but in case you missed it, it's at www.tracybingaman.com/ONE. Yeah, I just did an episode the other day on identity and how our identity is so tied to what we do. And I'm sure a lot of these patients that you're seeing have this career or this job that has been very fulfilling or even just a really huge part of who they are. And so then they get this diagnosis, and their life is largely divided before and after that diagnosis. So the diagnosis happens, and then they're having to make these accommodations, whether it's in their physical activity or their ability to work. And so much of our identity is tied up in that. That do you see patients struggling with, oh, I can't work because I'm coming to treatment every day, or I can't work because of I'm recovering from surgery. So what does that look like for your patients?
So, uh, my patients are rock stars. I'm just going to tell you. Some of them are working full time and going through radiation 5 days a week. And it's like nothing, there's no hiccup in their life. Some of my patients are greatly affected from surgery or from chemo. They cannot work. They need a little more help or resources to help them kind of get back on track, whether it's mentally, financially, however way we can help them. That's why our social workers, we work very closely with our social workers to help them kind of get back to a comfortable position. It may not be how it was, before the diagnosis, but let's get you back to where it's an acceptable level for you. And that's huge because you're absolutely right. Their identity is tied to what they do and who they are in society, just like all of us. So if we can get them back to an acceptable level where they say, okay, well, I had my cancer diagnosis. I cannot do this anymore, but I can do this, and that can make me happy. That's a huge part of it because stress, does cause a lot of physical ailments. If they're depressed or anxious, or they're just not dealing with the stress of everything, very well, it affects how they look at life. And we don't want them to be suffering through this cancer. We want them to thrive after cancer and cancer treatment. We want them to thrive. We want them to have the best quality of life that they can have at that moment.
Yeah, I think that's a beautiful reminder that curing the disease is important, and like getting them to cure, getting them to remission is such a great goal. And also, in that process, remembering that there's a person there who needs to, feel a certain way, who is sort of grappling with this change in their life, who's trying hard to get back to a place where they wake up every day and they don't feel like this cancer is all consuming. It's all we ever talk about. It's all we ever do. So how do you guys help people who are dealing with that? Because there is this period, I think, immediately following diagnosis, when we're doing active treatment, when we're doing surgery and recovery, that almost everything feels like it is about the cancer, the recovery, the treatments. How do people kind of deal with that and get back to a point where, like, as a survivor, that they're transitioning out of that and into kind of normal everyday life, whatever that looks like post diagnosis, post treatment?
I think that varies with every patient. Some patients, they live in the um, let's talk about cancer. Everything, my whole life is now all encompassed about cancer. I wake up about my cancer diagnosis, and that's okay. Like if they want to live there for so long, that's okay. There are other patients who say, you know what, I have been diagnosed with cancer. I want to get this taken care of, and we're done. And so you have to kind of weigh the patient where they're at. Some want to just kind of live in that moment. And when they're ready to get out of, having every single day be about their cancer, when they're ready to get out of that mental mindset. The social workers have support groups and they have other resources that can kind of help them get through that as well. We have a psych PA who can help as well, help them move through that position and that mindset. But we have also other patients who are just like, oh, this is just another task. Let's get this done. And then I go on with my life, no matter what it looks like. So just really listening to the patient and seeing where they're at is huge.
So, how do you, as someone who is your own unique individual, as a provider dealing with something that's, I think, very scary for all of us? Cancer is not a light diagnosis, right? This is a heavy topic. You're dealing with patients who are maybe being palliated, maybe end of life, maybe last resort. How do you take care of yourself as you're taking care of these patients in a way that's sort of emotionally heavy for you?
What a great question. Thank you for asking. Uh, I I work out a lot. I exercise. I will walk the dog for an hour after a really hard work day by myself. I just need that time to just rest my mind and, kind of go through my day and just put it aside. It's a very, you know, working in this industry, there's a lot of good news and there's a lot of bad news. And as a provider, it's how well you take care of yourself. So to me, my sleep regimen, my workout regimen is my self care. That is absolutely huge to me. And I think it's vital every single day. If I need to cry it out because of a patient, I cry it out, I go do my thing, and I'm human. So I go do that, and then I'm, on my way and I move on, just like all of us providers do. We just, keep going.
Yeah, it's an important reminder that finding what works for you, whether that's exercise or sleep or calling up a friend and decompressing, that we need these tools, because if we don't complete the stress cycle of kind of dealing with life and death and pain and sorrow and joy, all of the things that we're likely to see on any given day, if we don't sort of complete that adrenal cycle, complete that stress response, then we live in that state of fight or flight all day. So being in that state of fight or flight, like you're in the ICU, you're in a busy clinic, you're dealing with patients, you're making decisions. Like that's normal for that to be happening. But I think what you're doing when you're walking the dog is you're getting out of that. So you're completing that stress response. You're able to sort of decompress, process what happened during the day, and move on to the next part of your day, which is stepping into whatever other roles you're fulfilling. But if we don't do that, that's when we end up like laying in bed thinking about all of the things that happened during the day, checking, double checking, sort of in this almost anxiety like part of our mind where we're like, did I order that? Did I check that? Did I call that person? Where you're kind of decompressing when you're trying to go to sleep. Because I think oftentimes, unless you make time to decompress between work and home, when you lay down at night may very well be the first time that you've slowed down enough to process what happened between 9 and 5 or 7 and 4, whatever your office hours are. So for you, that's like walking the dog. Do you have any other like decompression rituals or anything that you do to help after a busy day or a stressful day?
Well, I know myself. It takes me about an hour to decompress from a work day. So I will hit the gym, hit the gym by myself, and that's just my time to get all the stress out, everything out from the work day. When I go out for a walk outside, fresh air, that helps me. And my sleep hygiene is huge. You ask anyone that knows me, my sleep hygiene is huge. So I think those things. The other thing is I do enjoy, seeing. I have an 11-year-old son. I enjoy seeing him enjoy his activities. Something about it that I just enjoy watching him. It just takes my mind off everything.
Mm, yeah, something else to focus on and something positive to see that makes you
Correct.
smile. There's a lot of value in that for
Correct.
sure.
As well as travel. I do love to travel. That's my big thing as well.
Now, talk to me about when you're off. So, when you come home at the end of the day or when you take a vacation and you're traveling, are you checking email, checking your in basket? Are you worrying about your patients or do you have some good support from the office where someone else is kind of taking over those tasks so you can be fully off when you're off?
When I come home, I try my hardest to just be done as much as possible. Be done. If there is a phone call or a task that needs to be done emergently, I will address it. But when I'm home, I'm home.
Yeah, which is how we can decompress is by not being on, not being in our inbox, not being doing, notes in the evenings and that kind of thing. So, while we're on this topic, I want to touch a little bit on this lifestyle change. So, you used to work in the ER, which is obviously a much different, whole different world as compared to where you are now, whether that's speed of visits, sort of how thorough things are, and also this amount of support that you have, this great team and this great social support for your patients where you are now. So, talk to us about what your life looked like when you were working in the ER and what prompted that change in specialties.
Like like I tell everyone, I don't think I did not pick the ER, but the ER chose me, and it is a fantastic specialty. I was in the same ER for 14 years. My coworkers and colleagues, they were my second family. I spent more time there than at home most of the times. Um, the schedule is very varied. One month you'll work mornings, the next month you'll work nights. Sometimes in between you'll work swing shift. It was all over the place. You worked holidays, weekends, nights. I think it's fantastic. But at that time, when I left after 14 years, my family needed something a little more stable of a schedule. My son was heavily involved in extracurricular activities, and I was realized that I was missing a lot of it, and he was growing up fast. So, as much as I loved the ER, I had to make a crucial decision.
And so, did you have to look for a while before you found your current position, or how did that work?
Actually, it was about the networks that I have. Um, I was slowly looking for another position, something that would kind of work with my son's lifestyle. He pretty much works and lives in 8 a.m. to 8 p.m. lifestyle, and the ER was not conducive to that very much at all. Sometimes it was, but most of the times, 90% of the time, it was not. So I was just slowly looking. My best friend, who her and I went to PA school together, called me up and said, "Hey, there's this great inaugural position, PA position in radiation oncology. They've never had a PA before. I think you would be great for the role. They just need someone who's just going to take this position and just go with it." And I said, "Okay, well, let me look at it." And she's like, "It's close to home and it will give you the 8 to 5 lifestyle that you want. And they only work 4 days a week." And I said, "Wow, let me sign up for this." So I applied, not knowing really what am I getting into? What is this radiation oncology? Is this some elusive thing they do in hospital basements? I have no idea. I had in the ER, I really had not seen a lot of patients with any radiation side effects, which is a good thing. I mean, now I look at it as this is a very good thing. We don't send patients to the ER often for radiation or radiation side effects. However, I did take care of patients in the ER for other types of cancer or sepsis or other related problems due to cancer. So I had some familiarity with treating cancer patients. And that's about it. And so I did my research on radiation oncology, what this all entails. I was worried, well, what if this is a big mistake? What if I'm leaving this great ER family for something that I don't even know what I'm getting into? So I had interviewed with the group that I currently work with now. I realized I think this is gonna be a great fit. And my attending at the time who had interviewed me, he thought the same thing. And we didn't realize this until later, until I was hired. Once I realized it was a good fit, they offered me a position. It was a huge learning, huge learning curve.
Oh, yeah. Yeah. Any new specialty, you have to learn a lot. And I think that when there is that, you're the first PA in the department, or even the first PA fulfilling that kind of role in the department, it seems like it's a double-edged sword, right? So, like, it's this great opportunity. You can make it your own. And also, you don't really know exactly what to do in this specialty because you've never done it before. They might not really know how to utilize a PA in the department. So were there growing pains? Like, did you come up against them saying, "Oh, you can't do that," or you saying, "I want to do more"? How was the integration once you actually got hired and started?
Oh yeah, I think there were growing pains for all of us. The one of the attendings who had interviewed me, he was familiar with PAs and their role in a group setting, clinical setting, hospital setting. He was very familiar with how PAs work. The Some of the other colleagues were not as familiar. They knew about PAs, but they were not as familiar working directly with them. So there were some huge growing pains that we kind of worked through, and the matter of just what is she going to do? Here's this great idea, but what is she going to do? So we slowly hashed out through that, and I told him, I said, "Listen, I take care of all these patients in the ER. I can do this." When in doubt, when they had any doubt, I could do this. Like, just show me that. Just give me the opportunity. Let me show you that I can do this. And sure enough, it was a lot. It was a lot of growing pains. A huge learning curve for everyone.
And I think that the physicians in that situation, they're not trying to make it hard for the PA. I think they're trying to make it safe for the patient. And so I think that sometimes that gets confused and it can lead to sort of resentment, or like they're trying to keep me from doing my job, and they're like, "Well, we don't want you to not do your job. We just want to make sure that these patients who we care so deeply about, who we trained forever to be able to take care of, we want to make sure that those patients are safe." So being able to say, like, "Hey, I'm competent. Like, this is what I know how to do. I don't know how to dose radiation," right? Because that's not something I did in the ER, but I know how to learn how to dose radiation. So if you're willing to learn and you're willing to say, "Hey, I don't know how to do that specifically, but I am trainable," right? I'm trainable to do anything. And I think that is truly the beauty of being a PA, is that if you are willing to learn and if you have a group that's willing to train you, you could do any specialty. Anyone listening to this could do any specialty, regardless of whether they'd heard of it or knew what they do at all, as long as they're willing to learn and they have a group that's willing to teach. And it sounds like that's what's happened at your job.
I absolutely 100% agree with you. If you're open-minded and you have great communication skills about what you're comfortable with and what you're not comfortable with as a PA, I think is vital to um, communicate with the group, the physician group that you're working with. I think it's amazing if you are moldable and open-minded to learn, and you let them know that, listen, I'm open minded, I'm willing to learn. You teach me. This is a valuable moment for me. I will go off with this. I will do wonders for your practice. I think that's the key.
Yeah, and that open communication and saying, this is what I'm comfortable with coming in. I'm really comfortable with an H&P. I'm very comfortable managing the patients. Like, I don't have a problem with that because I have all of this experience doing that in the acute care setting in the ER. But here's what I don't know. Here's what I do need to learn. Like, here is the gap between my current practice and my current knowledge and where I need to be functioning independently, seeing these patients. So, do you have your own panel? Like, is someone coming in and seeing you for the initial consult? Are you their point of contact? Do you alternate with the physicians? How do you work visits and managing patients on a long-term basis?
So in my practice, we usually alternate. So I alternate each visit with one with the physician, one with myself. I work for a total of six physicians. I always tell my patients it's six against one.
Yeah.
you know, um, but they all manage their patients pretty much the same, where I see them, and then the next visit is with the physician. I believe that's the best way to go about it because it's all eyes on deck. It's not just one set of eyes, it's everyone's eyes. And I think that's a much better way to manage patients.
Yeah, I think if that works well for you, and in my experience working with a big group, if there is consistency about what we're doing protocol wise for this or for that, then it's easier as a PA to step into seeing visits 1, 3, 5, 7 because you know what to expect because there is a protocol. When you're working for 10 different physicians and they all do things a little differently, you spend all day like, which way does this person do this thing? But if there's a standardized protocol.
Yes, I absolutely agree with you. If there's some uniformity in the practice, I think it makes it so much easier as a PA to kind of just run with that. When there's not, I think that's where we kind of run into a little more of a hard time. However, as your role as a PA, you can bring that up.
Yes. Yeah, it's a great opportunity for practice improvement if you say, hey, you guys might not even realize this because you might not really be comparing notes about what you're doing, but I'm seeing your patient. So I see that, this is working well for pain control. Like, should we adopt this universally as a protocol across the practice? And it's a great way to add value and to improve your patient's experience. If you see like one physician is doing things a certain way and there's a good benefit there, I think you're in a unique position where you're seeing patients from different providers to be able to do that. Now, how has I have two more questions before we wrap up. One is, how has this been accepted by the other people on the oncology team? So you sort of stepped into this practice, six physicians, one PA, where I'm sure that sometimes you're calling the surgical oncologist, you're calling the medical oncologist, you're calling the primary care physician, and you are sort of quarterbacking the team for that patient if something's happening on the time when they're seeing you. Has that been generally accepted by the other people on the team, or have you had pushback about being a PA and not a physician in that role?
No, I think that the team that we work with is very accepting of PAs and NPs. Um, Basically managing the patient. I have not had any pushback, really.
That's good.
Yeah,
That's
fortunate.
awesome. That's not true in a lot of areas of the
Yeah,
country. So I'm glad
yeah.
to hear
So
that that's happening for you.
that is what I've heard. Yes.
And then I want to talk about the downstream benefits. So I think if there's someone listening who's like Radiation oncology has always been an interest of mine or something that I've thought about, but I've never seen a position listed for it. They probably know of the Rad Onc group in their city or in their town who's seeing patients because they're doing primary care or they're doing general surgery and they occasionally do oncologic cases. And that person's like thinking, she's doing it, right? Joann is doing it. It happens, it exists. I want to do it. And they're thinking, I want to present a case to my local group. Can you talk a little bit about sort of the downstream benefits? How has this benefited patients and them waiting for appointments or your physician's availability? So, how has you being there improved the overall group and your physician's quality of life and your patient care?
Well, this is from my point of view. Of course, the physicians have their point of view, but I, I think that I have provided improved access for patients to see a provider. A lot of the physicians that I work with, their schedule is just jam packed. Constantly, a lot of the times, the patients will be like, "Well, I want to see Doctor So and So," and I said, "Well, Doctor So and So, you won't be able to see Doctor So and So. The schedule's booked up for a month. You could see me in a week, 2 weeks. I can fit you in." So I think the access to quality care is a little faster having me around. I also go to 3 different sites, um, so hospital sites. So I'm pretty busy chicken, put it that way. And the physicians oftentimes stay at one site. Sometimes they'll go to the other sites, but their schedule is not as open as mine. So the availability of good patient care and continuum of care is present, as well as being able to contact a provider. They can contact the office and they can call and ask to speak to someone. That's me. I can do it. Um, so I think being a PA and working for a very busy radiation oncology department is very beneficial to them, because it helps with the continuum care. It helps with patients getting access. Patients don't want to wait a long time. If they've got a problem, they don't want to wait a long time to see a provider. They want to have this problem taken care of, and that's where a PA can kind of come in and promote themselves and say, listen, all these physician groups, like I can give the patients the greatest access of care, and I can give it fast.
And you can scale the impact that your physicians have. So if they can normally carry a panel of X patients, if you're taking off every other visit and you're taking that onto your schedule, they have more room for new patients themselves. They have more room to see the really problematic ones, the ones that are sort of reaching that threshold. People that need that physician level of care can access it and not have to wait so long to be able to get on their schedule, as you
Absolutely.
said.
The high acuity patients, the physicians, will take care of a lot of the inpatients, consults, emergency consults. The physicians can take care of. I can take care of the more continuity of care, the more stable patients.
Yeah. I think that older term that we don't use anymore, physician extender, which they used to call PAs like way back in the day. I think that I'm glad we're not called physician extenders anymore, but I think the math behind it makes sense, right? You say, hey, I come in, I take off some of this workload from what the physicians are doing in an appropriate way that I've been trained to care for them, that they feel comfortable with their patients transferring care to me for continuity or maintenance or whatever it is. And you're exponentially improving the access that the physicians have to the other patients that need them. It's a huge benefit to the patient population. It's a huge benefit to the practice because patients really care, as you said, when they pick up the phone and say, either I need to see you for the first time, or I'm having a problem or a complication, or I have concerns, or I need to see someone. The time in which you get that patient on the schedule is really crucial to them because to them, that really matters. Whatever problem they're having, whatever question they have, getting that question answered, getting that problem solved is of the utmost importance to them. So if you can take good care of those patients, it just improves everything for everybody down the line.
Absolutely. And, practice wise, your practice becomes more responsive. And so patients love that. They said, this practice always responds. I can always get in, and they tell a minimum of 6 of their friends, of their family members, who may need cancer treatment. They say, "Oh, well, go to this practice because they have such a great working model. You can always get in, or you can always get a hold of someone, and they provide great care." It's a huge marketing benefit for practices to have PAs.
Yeah. I think that the investment in a great PA, it's less than a billboard, right? It's less than a billboard, but you're providing amazing care to patients. And there is this downstream word of mouth benefit that is going to occur for all of the patients. And just like when you're looking for a hairdresser, you say like, "Hey, who cuts your hair?" The same is true when people are looking for a good group to see for anything. That's applicable across the board, specialty wise. People will leave practices when they can't get a human being on the phone, when they can't get the questions that they need answered, and when they can't get into the office. So if you're pitching yourself to a group, if you can highlight how that will improve for patients. And I think those things are a problem at a lot of practices, right? They're just not enough providers in the group to support the number of patients that they have. And with our aging population, I think especially practices that take care of people who are in their advanced years. We have a lot of people turning 65, right? So people who are, on an age, if we're taking care of those patients at this group, it's a great time to pitch yourself. It's a great time to say like, "Hey, I can add value to your team. Here's how I can do it." This is like a model that's happening other places, which is so, so cool to be able to use this platform to share this with other people who are listening. So Joann, if people are just so enamored with you like I am and want to either send you a little love note or have other questions or inquiries about radiation oncology, what's the best way for them to get in touch with you?
Would probably be to call the office.
Okay.
It's Memorial Radiation Oncology.
Okay.
It's
I will
Memorial,
go ahead.
yeah, it's Memorial Care Radiation Oncology Group. So yeah, um, they are a fantastic group to work for, and I think as a PA, I think your goal and your role is, in a way, a middleman. One, to be the advocate for the patient. Two, to advocate for yourself, especially with physicians and other providers. Um, some of them don't know the full role that you can do as a PA. So your job is to advocate and market yourself and show them that you can do all these great things that they may not know about.
So awesome. Well, thank you so much, Joanne. This has been eye-opening for me. I felt like I knew a little bit about radiation oncology before we started, and I definitely know a lot more now, and also the role that PAs can fill in that job position. So thank you so much for sharing your time with us. Thank you for being available to come on the show.
Thank you, Tracy.
There you have it. It's so inspiring to hear from other PAs in different specialties, especially specialties where PAs are relatively new or just breaking into the specialty. So, if you've been wondering, do PAs even practice in radiation oncology? I am so glad that you tuned in to today's episode. Thank you, as always, for listening to The PA is In. What most of our listeners do is they will head and subscribe so that next time an episode drops, it'll be waiting for you in your podcast queue. So you'll never have to worry about missing another episode of The PA is In. If this episode helped you at all, if the short stories and the tips that we shared or the advice that we gave resonated with you, helped you to learn something, or even made you feel less alone in your role as a PA, I am so glad that this show is meeting you where you're at. If you want to say thanks, head on over to whatever platform you are listening to this. My favorite is iTunes. Head on over to iTunes or Apple Podcasts, leave a 5-star rating and a review telling us why you love the show. Those reviews are life-giving to a show of this size. I love to read them. It is an uplifting part of my week when I log in and see all of the reviews that you guys have been leaving. And also, it helps other PAs just like you to find the show. Now, if you feel like this episode is needed by one of your friends or colleagues or PA school classmates, do them a favor, screenshot it, share it on social, text them, or email them this episode, the link so that they can tune in themselves. Thank you so much for listening to the show by PAs for PAs, where we help you to design your life so that you can live long and prosper. It's your turn to get inspired, take effective action, and become one of those unicorn PAs who loves their job, has abundant energy, time to spare, and work optional financial freedom. Until next time, this PA is out.